Good afternoon and welcome to Alterations in Nutrition, Fluid, and Eliminations. Please don't forget all those problems with gastritis, ulcers, and other problems with digestion, including GERD, and we will be discussing those this evening. The objective is to necessarily look at gastrointestinal assessments and findings and to see what the actual or potential nursing diagnoses could be, to analyze the pathophysiological changes that occur in the need for water, food, and elimination, list expected outcomes for actual and potential food, water, and elimination problems, and select nursing interventions based on evidence-based practice, which you all are doing on your care plans, that prevent, maintain, restore, and rehabilitate patients with deviations in food, water, and elimination. We want to understand the dietary modifications that are dependent upon the pathophysiology to differentiate between pharmacological agents used, including their action and nursing responsibilities, and to use expected outcomes to evaluate the effectiveness of our nursing interventions. According to the NCLEX test plan, we are looking for safe and effective care of the environment and how to manage our care, trying to promote health and maintenance, and the psychological integrity of a person who has gastrointestinal disorders, physiological integrity, what's going on with their basic care and comfort, and yet the pharmacological or parenteral therapies that are consistent with these diagnoses, and the reduction of risk potentials and psychological adaptations. And here we go again with the anatomy and physiology. The oral cavity being the teeth, tongue, salivary glands, and jaw. The pharynx is that muscular tube behind the throat. The esophagus is a 10-inch long muscular tube with the bottom end of it being the lower esophageal sphincter. The stomach is in the upper left quadrant of the abdomen, and it's used for digestion. It contains a sufficient amount of gastric acid, and don't forget there are 3 layers of the gut. Consists of the outer longitudinal, the middle circular, and the inner oblique. There's also chyme in there, and the pyloric sphincter is at the end of the stomach, excuse me. The small intestine is a 1-inch diameter. It's about 20 feet long. It includes the duodenum, the jejunum, the ileum, the ileocecal valve. The large intestine continues from the cecum to the anus. It's about 5 foot long and 2 1/2-inch diameter. Again, at the bottom of it is a valve, the ileocecal valve, the appendix, the ascending transverse and descending sigmoid rectum. So there's your beautiful picture of the digestive tract from the esophagus all the way down to the anus, looking at which comes first, the duodenum, the jejunum, the ileum, and the type of bacteria that is necessarily consistent with the gut, and how maintenance of that is essential for not only proper digestion, but also for immune system as well. As the body ages, unfortunately, saliva decreases by 33%, which, don't forget, is your major enzyme for digestion. The amylase is contained in the saliva. The taste is less, and peristalsis also decreases. The lower esophageal sphincter loses its tone and unfortunately allows for, at times, GERD. Gag reflex is a little bit weaker, and the hydrochloric acid is not quite as strong as it used to be. Surrounding the intestinal tract is the peritoneum, which is like a membranous sac, which basically holds kind of everything intact. Inside is the liver, which releases bile and it stores glycogen. So sometimes that liver comes out to need when a person's blood sugar is low, and the stores of glycogen kind of help restore the body in crises, low blood sugar crises. The gallbladder holds about 60 milliliters of bile, and the pancreas contains the digestive enzymes. While performing an assessment, the subjective data is asking a patient what's going on, where is there any pain, what's up, how are you feeling, are there any symptoms that are aggravated, or is there any alleviating factors? What is the timing of your gastrointestinal upset? Is it after you're eating, before you're eating? What is going, after you have a bowel movement, before you have a bowel movement, the severity of it. Make sure you are gathering as much useful data as possible and challenge your perceptions and the patient's perceptions as well. Do they have any history of disease? Is there any corresponding symptoms? What does their stool look like? Are they on medications, including any laxatives or NSAIDs? Including nutritional assessment, make sure you could gather a person's eating patterns by a 24-hour recall. noting their allergies, any problems that they may have had with eating, any certain foods that they may have particular to their diet, any vitamins, any weight changes, and indigestion. The objective data should include their current height and their weight, and is it appropriate for their frame. Any changes in the oral cavity, how are the teeth, any cavities, any shifts in dentures. Sometimes when a patient is lower, they lose weight, the dentures become looser. Check the abdomen and inspect, auscultate, percuss, and palpate in that order. If you palpate too early, you're going to create bowel sounds. And if a person is in any way hypoactive, you don't want to make it seem better than it could be. Test of the gut that you may want to validate and see if they're present in the chart is a carcinoembryonic antigen, a CEA, which is basically, it's a test of a type of protein in the body. After birth, it does drop off, but a high level of a CEA can be a sign of certain types of cancers. Some include cancers of the colon and the rectum, prostate, ovary, lung, and thyroid, and sometimes of the liver. You want to look for total protein and albumin levels. They're not supposed to be too high, or for that matter, too low. Lactose intolerance, necessarily associated with elderly and sometimes Asian, where the lactose doesn't break down very effectively. You want to check the CBCs, bilirubin, ammonia, thinking of Mr. Liver, PT, amylase, lipase. When you're looking at the stools, check the color of the stool, especially if they appear too white, necessarily maybe gallbladder disease, gray, red, bleeding, black and tarry, old bleeding, green. Med, sometimes pyridium, can cause discoloration of the stool. Sometimes the characteristics of the stool include stenoturia, which is basically the excretion of abnormal quantities of fat in the feces, owing to a reduced absorption of fat by the intestines, melanin, sometimes mucousy or mucoidy, and white. Sometimes stool or occult blood, a stool can be tested for occult blood. It's called guaiac. It's called a hemoccult. Usually it's a test of stool. Please make sure that if you're taking a sample of stool that you should wait a few hours after eating red meat. If you're taking any aspirins, that could also cause temporary localized bleeding. NSAIDs, turnips, and horseradish can necessarily change the color of blood in the stool. Occult blood is usually hidden blood. It is a smear, they put a smear of stool on a guaiac paper and use this hemoccult solution, and if there's a blue ring, it's positive. Usually you wait 72 hours after eating red meats, or you take aspirin, or you're on any NSAIDs. And again, they will all give false positives. Vitamin C will sometimes yield a false negative, so you want to know what their history is of multivitamins. A stool for ova and parasites will necessarily test that for any eggs or any parasitic residue from a bug that may be in the stool. And also a stool for lipids, just to check fat layers and how fat is breaking down. Tests for the GI system usually require the patient to be NPO prior to the test. If they're using a dye, please make sure you're checking for renal function of the BUN and creatinine. And you want to make sure that the kidneys can handle any of that. And especially if a person comes back before they go in for those tests, you want to make sure they're on IV fluid so that they could flush it out of their system as soon as possible. If they're doing an endoscopy, you want to make sure that they're cleaning out the bowel. In the performance of an endoscopy, you have to make sure for a risk of perforation of that bowel, and you're always going to be checking for signs and symptoms of a post-endoscopy patient as they're coming back. Post procedures, make sure they're drinking and they're trying to expel any of those contents that were introduced. Maybe a little bit out of sequence, but radiographic tests, whenever there is a dye that's introduced or some type of film, you have to make sure that there is you know what the kidneys are doing and you know what the lab values are doing. So for a radiographic test, know what the kidney lab values are. And also too, like for the CT, sometimes they do it with dye as well. So the CT, you have to be careful that you are aware of what the kidneys are doing. And when you're having a barium enema, unfortunately the barium itself that you're swallowing, or the barium swallow, you have to make sure you are moving those I don't want to call them medications. They're almost like film markers. You're trying to flush them out of the system as fast as you can. Patients are usually kept NPO. for 6 to 8 hours. For the upper GI, they're given a drink, and then they're given a laxative, trying to clear out the intestinal tract as much as possible. And the same thing for the lower GI tract, clean out the bowel. It usually starts 48 hours prior to the test, and they're given enemas as well. And post all of those procedures, make sure that somebody is drinking as much as they can, as much as they can tolerate. In a case of an endoscopy, you can have an upper GI endoscopy, EGD it's called. Again, the prep is to be kept NPO, and a local anesthetic is sprayed to kind of stop the gag reflex as they introduce a tube camera into the esophagus. After the patient comes back from the procedure, please make sure that there is a gag reflex present, because you don't want them to be fed as well, and there's no bleeding or anything associated with the test. A lower GI proctosigmoidoscopy and a colonoscopy, again, same thing, check for perforations, but get the patient up and walking to release some of that gas. In a gastric analysis, they might do something called a breath test, which is a hydrogen test, and that is to check for that H. pylori, which is necessarily associated with ulcers. And also the other test is a magnetic resonance imaging, or an MRI. Usually there are no dyes introduced for that. Again, you're looking at those two procedures. One is a EGD, where they're looking at the lining of the esophagus, the stomach, and the duodenum. And then the other one is the colonoscopy, which is a scope inserted into the anus and going up into the bowel systems, up to the high part of the large intestine. Therapeutic measures may include the use of a gastrointestinal intubation or an NG tube. An NG tube is usually used to decompress. It can be used to irrigate with normal saline. But when a person has incredible nausea and vomiting, has a GI blockage, to decompress, the best way you could do it to relax the intestinal tract is to use an NG tube. Sometimes you have tube feedings, which include gastrostomy or jujuostomy. Again, per different location of that tube feeding, you're going to change the formulas because it's lower into the intestinal tract, and you want to make sure that the protein breakdown in the gastrostomy tube, it can break down the protein, but maybe not as effective in the jujuostomy. So you might get a pre-digested form of proteins. The total parenteral nutrition is used as the only source of nutrition that the patient may be receiving, whereas PPN is meant to act as a supplement and is used when the patient has another source of nutrition. Administered into smaller veins, the solution is lower in nutrients and calorie count in the PPN than in the TPN, because the TPN has absolutely everything you could possibly want as far as nutritional supplementation. This slide is kind of gearing us up for the drugs that are associated with the GI system, and it does, lead into that. But first, you're looking at the drugs and how they are targeted. And one of the things is you got to understand that the parietal cells are involved in the targeting of these drugs. The parietal cells are necessary for acid production, and you have 1 to 3 liters of hydrochloric acid each day. It's necessary to break down food, and it's helpful it is involved in the secretion of the intrinsic factor, that vitamin B12, without which we really don't have really good blood production, and we don't really have a good immune system. The stomach lining is also very important because it secretes that mucus layer and bicarbonate ions to neutralize acid, and sometimes that becomes incredibly necessary. So one of the medications that you do have, they're called H2 receptor antagonists, and antagonist means it's stopping H2 receptors. H2 are responsible for increasing acid secretion in the stomach, so you could get that if a person has too much acid production, they suggest that you take an antagonist, something that will stop it. Well, that includes the DINE endings, the DINE pepsid, the ranitidine, the cimetidine, the famotidine. I'm sorry, I'm saying those terribly, but the DINE endings necessarily let you know that it is a H2 receptor antagonist. They could be given in IV or in PO preparations. Please make sure you're checking the kidney and liver function. Long-term use may lead to vitamin 12 deficiencies, but that makes sense because we were talking about those intrinsic factors. Alcohol and smoking and certain foods can increase gastric acid secretions. P.S. Changes in evidence-based practice are indicating that what is the best way to naturally shut off those H2 receptors is to provide a diet that has more acid in it. Can that necessarily have a better job in stopping the acid secretion? If you have enough, doesn't your body have that feedback system where if it has enough, it shuts down? So introduce it through nutrition and maybe the body won't be producing the acids. Just a thought. Other type of medications are proton pump inhibitors. They block the enzymes responsible for secreting hydrochloric acid in the stomach. They are also known for the azole endings. That's with the Nexium, the Prevacid, Prilosec, Protonix, and Zagrid. Zagrid is just a combination med. It's the oprazole and sodium bicarb, and that's what Zagrid is. So it kind of gives you that buffer, which is that sodium bicarb in it. But again, look what it's doing. It's trying to stop the secretion of hydrochloric acid, and look specifically at the azole endings. You don't need to know the other name of the medications because you know it solely by the azole endings and the type of endings that these medications have. These medications are necessarily well tolerated in the short term. Please make sure it is only the short term because you're supposed to use that time that you're on the medication to figure out how to change your diet in order to adjust to whatever condition you may be experiencing. Long term, make sure you're monitoring liver functions. You're looking at serum gastrin levels. Do not use them when you're pregnant. Take the medications 30 minutes prior to eating. Do not crush, do not break or chew them. And be careful when you're using them in combinations with antibiotics because sometimes it could mute the effect of the antibiotic. You don't want that to happen because you are not getting the full benefit of an antibiotic, which can cause superbugs. Side effects include diarrhea, headache, dizziness. Teach your patients about GI bleeding and to report it and any pain. Eat foods with beneficial bacteria, which are those lactobacillus acidophilus things that you want to make sure people are eating. Antacids neutralize stomach acids. Those are those common things you get over the counter. And actually, too, some of these things that they're putting in calcium for people who have low calcium levels, and they are pretty good. So people take them now instead of calcium tablets. Please understand, Pepcid, you, again, don't want to be on it for too long. The antacids do neutralize stomach acids. Drugs, peptic ulcers, and GERD are available over the counter. They include aluminum, magnesium, sodium, and calcium based. Some of them are chewable and liquid formulations and are available. There's one that's very, very commonly used, which is the simethicone based. In many commercials, you'll see the use of simethicone coating the gut, and it neutralizes the stomach. Pepcid Complete is one of those things. It contains calcium carbonate. There's other forms which have a magnesium hydroxide and famotidine, which is your Pepcid. Other medications include aluminum hydroxide, which is Amphigel. Aluminum, watch out for, associated with Alzheimer's disease. Calcium carbonate Tums, and a lot of times people are using the Tums for their ingestion of excess calcium. Magnesium hydroxide, milk of magnesia, very common medication over the counter. Combo medications include magnesium and aluminum hydroxide with simethicone, which are your Mylanta and your Mylanta Plus. And your sodium bicarb is that tried and true Alka-Seltzer. Please make sure you're monitoring for the kidneys. Magnesium and aluminum may cause diarrhea, and calcium may cause constipation. Teach patients if they to avoid sodium if they have congestive heart failure and hypertension, to take 2 hours before other oral meds, and make sure that they shake the suspensions. Antibiotics are currently being used for H. pylori. Kind of within the last maybe 10 years, they started using antibiotics for ulcers, especially if it is of that Helicobacter pylori, which is well adapted as a human pathogen, unfortunately. It is so they use antibiotics such as amoxin, Biaxin, Flagyl, tetracycline. Other miscellaneous drugs would be like a Carafate, which consists of a sucrose-based aluminum hydroxide. And also other antibiotics that are used for the gut include doxycycline as an anti-ulcer drug, which may lead to effective therapies for gastric ulcers. Combination therapy of doxycycline with other anti-ulcer drugs such as Pepcid necessarily do help for gastric inflammation, can be used for gram-negative and gram-positive bacterium. It inhibits bacterial protein synthesis. Adverse reactions could be a category D. Please don't give it to pregnant women, for children under 8. Intervention should be avoid milk products, iron, antacid tablets, and expired meds can be considered toxic, so please be careful with them. When you are thinking about the common disorders that people go to the doctor's office for, they include nausea and vomiting and bowel disorders, diarrhea, things that are not digesting well. Problems that people do have with the small intestines, that duodenum, the jejunum, and the ileum, is bleeding potentially, celiac disease, Crohn's disease, infections, intestinal cancers, intestinal obstructions, irritable bowel syndrome, and ulcers such as peptic ulcers. And a lot of times when you're looking at small intestine problems, those are the problems that people will be experiencing. Peristalsis is controlled by the autonomic nervous system. Food traveling time takes about 3 to 6 hours. The large intestine serves a major function in the reabsorption of water, the synthesis of vitamin B, complex vitamins, and vitamin K. Laxatives promote bowel movements and are over the counter. They are also called cathartics. They are available in tablets, liquid, and suppositories. And a lot of times prophylactic laxatives are given for people who are known to be basically constipated all the time. Many types of laxatives include bulk forming, which is selenium, muciloid, which is Metamucil, polyethylene glycol, which is Marilex, which really will give you diarrhea really quickly. You mix with 8 ounces of water, fruit juice, or milk. Take with 2 glasses of water. Make sure you're drinking a lot of fluids when you're doing this. Saline and osmotic type formulas pull water into the colon. They're highly potent. They work within hours, and you monitor for dehydration. They include magnesium hydroxide, which is milk of magnesia, polyethylene glycol, which is your Miralax, your sodium biphosphate, which is your Fleet's phosphosoda, and lactulose. Lactulose is one of those pretty special little characters because it is used when somebody has liver issues and you want to get rid of the ammonia. Lactulose can be used to necessarily evacuate the bowel, but it also takes with it all of the ammonia as a waste product of a poorly functioning liver. Other types of laxatives include a stimulant, which is like Dulcolax, which is a biscodiol, Senecot, which is called Senna, castor oil. They irritate the bowel and they cause cramping. They are the quickest acting, but please make sure you don't have an obstruction before you administer. Stool softeners such as dulcosate sodium or Colase uses water and fat to be absorbed into the stool, so it kind of forces the more fluid into the stool. It's given for patients who have a risk of constipation or straining, especially those who have had things like hemorrhoid surgeries, and you don't want them to strain while they're having a bowel movement. Other agents include mineral oil. Please make sure you are checking the abdomen for distension. Make sure you're listening for bowel sounds. You want to know what their bowel movement patterns are and if there's any pain. Anti-diarrheals you could get over the counter. You could buy them at the shop, right? Especially if you're traveling, make sure you always have them on, with you in your luggage to make sure that if you ever have any episodes of diarrhea, you could use those. If they're chronic, a lot of times they give opioids, but we kind of know very, very quickly that opioids will necessarily cause constipation. Imodium might be those that are necessarily just needed to stop any severe diarrhea. Miscellaneous includes bismuth salt, Pepto-Bismol, kind of effective. And for nursing symptoms, check for any bleeding, monitor for dehydration, and monitor electrolytes. There are other prokinetic type drugs which are GI stimulants, and they include Regulin, uricholene, which are used to delay gastric emptying in people who have emesis and they're throwing up. Used in patients who have gastric stasis, things aren't moving. Given IV after GI surgery. Side effects include their CNS, central nervous system. They can cause tremors, involuntary movements, dizziness, depression. What type of patient would you not give this to? Look for patients who have tremors, who have gait disturbances, sometimes people who have dementias. Please don't give to patients who have Parkinson's disease, because you are giving them medications that are influencing dopamine receptors. So you don't want them to have prokinetic drugs such as Reglan. Anticholinergics are another yucky class of medications, especially for seniors. They block the neurotransmitter acetylcholine in the nervous system, and they inhibit the parasympathetic nerve impulses. They relax smooth muscles of the GI tract and inhibit GI secretions. Examples include atropine sulfate, Artane, Cogitin, Ditropan, and you know what, scopolamine patches. Unfortunately, these medications are known to cause memory issues. These type of medications are sometimes, when given to seniors, can cause those memory issues and almost giving the impression of dementia. So give with caution. Diseases of the esophagus. Gosh, they're annoying and they're very painful. Esophagitis. It causes reflux of the stomach contents. There are irritants, vomiting, and potential malignancy. Why? Every time an acid continues to burn the inside of the smooth mucosa of the esophagus, it becomes irritated. It's a constant source of irritation. Signs and symptoms include heartburn, pain, dyspnea, dyspepsia. Burping all the time, people feel very uncomfortable because they always get this feeling in their mouth, or they have to burp. Treatment is to get that pain relief, to give small, frequent meals, and to watch for certain foods to avoid. And sometimes that includes coffee, sometimes that includes broccoli. Barrett's esophagus is a really weird kind of situation. It's a condition in which the lining of the esophagus kind of changes, and it becomes more like the lining of the small intestine rather than the esophagus. This occurs in areas where the esophagus is joined by the stomach. Unfortunately, this is usually a precursor to cancers because the mucosal layers of the small intestine are not necessarily like the esophagus. And unfortunately, when things are starting to change and not as they should be, you're looking for cancers. And now I'm sure you've heard of GERD, or gastroesophageal reflux disease. It's the lower esophageal sphincter does not close effectively. Remember that LES? Signs and symptoms include heartburn and regurgitation. Usually a diagnosis is done with a barium swallow. Treatment are antacids, H2 receptors, cholinergic medications, a diet that is low in fat, high in protein, there's no milk, caffeine, alcohol, smoking, peppermint or spearmint. Nursing care, keep the head of the bed elevated, don't lie down after eating, and it's the same as esophagitis. And in our picture of GERD, look at where this esophageal sphincter is. And unfortunately, it's ineffective at that particular point, and the acids of the gut just kind of go into the esophagus and literally burn it. You could often tell a person who has GERD because they have awful breath. With nursing process for esophagitis or for GERD, make sure you take a very good health history, noting appetite, discomfort with swallowing, and when and which foods cause reflux. If there's any pain or regurgitation, when does it happen? Is there any belching? Is there any pressure? Is the food sticking to the throat? Is there any weight loss? Nursing diagnosis includes imbalanced nutrition, pain, knowledge deficit related to diet. Outcomes include nutritional intake, improving, reducing the risk for aspiration, reducing pain, getting education, maintaining your desired weight, and report no belching and no chest pain. Interventions include eating slowly so that it passes easily. Eat small, frequent meals. Keep their head of bed elevated. Do not lie down 2 hours post-eating. Do not eat or drink 2 hours before bed. Don't wear tight clothes. Make sure you're monitoring your daily weights. Education is to make sure that you're eating the proper diet and the correct positioning. Surgical interventions might include the wrapping the portion of the gastric fundus around the sphincter of the esophagus. Literally, you kind of move the gut up a little bit higher and you kind of absorb part of the sphincter of the esophagus. Gastritis is the inflammation of the stomach lining mucosa. It can be acute or chronic. It can be non-erosive, which is caused by the ulcerative Helicobacter pylori. It can be caused by long-term use of NSAIDs. Acute gastritis is rapid in onset. You have severe abdominal pain and belt and bleeding. Chronic gastritis, you could have I can't get it, heartburn post-eating, belching, sour taste, and not able to absorb that vitamin B12. Unfortunately, looking at a picture of the inflamed areas of the gut that is necessarily associated with gastritis. Ulcers are lesions in the mucosa. Get them too long sometimes, and chronic exposure, sometimes you could look at malignant development of these lesions. Ulcers and tissue can be lost in the lower esophagus, in the stomach, or in the duodenum. The stress ulcers secondary to systemic burns are known as Curling's ulcers. Stress ulcers in patients with acute traumatic brain injury are called Cushing's ulcers. So you have Curling's and Cushing's. The gastric body and the fundus are common locations for stress ulcerations, but can also be seen in the antrum and in the duodenum of the gut. Causes could be genetic, smoking, meds, NSAIDs, aspirin, glucocorticoids. Signs and symptoms include a gnawing, burning pain in the epigastric region, and it is relieved with food. If it's in the duodenum, it takes 2 to 3 hours post-eating for relief. Treatment is the prevention, rest, ice, saline, lavage. If you're bleeding, of course, it will cause vasoconstriction. Small meals, meds which might include antacids, those H2 antagonists, anticholinergics, and proton pump inhibitors. Peptic ulcer disease is related to stress, diet, alcohol, or caffeine, but some say it's because of that H. pylori. The lining of the stomach, the pylorus, the duodenum, and the esophagus is eroded, and it may go through many muscle layers into the peritoneum. Peptic ulcers also occur in the duodenum. Risk factors are between 40 and 60 years old, type O blood, and poor diet. Zollinger-Ellison syndrome is a condition in which gastrin-secreting tumors or hyperplasia of the islet cells in the pancreas cause an overproduction of gastric acid, resulting in recurrent peptic ulcers, so that's a syndrome in and of itself. The signs and symptoms include aching, burning pain, anorexia, and bleeding, of course, occurs late in the syndrome. The diagnosis is through your urea breath test, and also through an EGD, and checking for H. pylori. The only thing I could actually say about this slide is, ouch. It's a very, very painful process, and you can see how deep it can potentially go into the side wall of the stomach. Treatment includes 2 types of antibiotics: tetracycline, flagyl, Viaxin, amoxicillin, and one to decrease acid levels, tetracycline and amoxicillin. H2 antagonists are also used. The Zollinger-Ellison syndrome also give twice as much meds to decrease acids because it's just crazy, and it's actually a tumor that's causing it to secrete. Complications include, of course, perforations, hemorrhage, pyloric obstruction. Gastric bleeding in the stomach, it appears coffee ground-like through vomitus. Sometimes it comes up through the NG tube. In the intestines, you could get black tarry stools. Signs and symptoms include weakness, diaphoresis, shock. Always check for perforation. Treatment includes IV fluids, keeping the patient NPO, monitoring their H&H, inserting an NG tube, and O2. Peritonitis is an inflammation of the peritoneum. It's a serious condition that can cause death if it's not treated. The cause includes a perforated appendix or intestine or stomach perforation. Signs and symptoms include severe abdominal pain. The abdomen becomes very, very rigid and board-like. It's distended. There's rebound tenderness, meaning that you press in, you come back, and it hurts. Incredible pain. Fever and chills. High white blood count. Peritonitis, dangerous beast. Complications include sepsis, obstruction, hypovolemia. Treatment, O2, keeping the patient in NPO, a nasogastric tube, IV fluids, antibiotics, narcotics as necessary, and surgery to drain the cavity. Nursing care, a semi-Fowler's position, no quick movements, only because it hurts so much. Vital signs, and maintaining I&O. 2 types of gastric surgeries. Well, there's multiple ones, but you could have a subtotal gastrectomy. You have a Billroth 1 or a Billroth 2. Just please note the different locations of which the bypass is. You could have a gastroduodeostomy or gastrojejunostomy. or you could have a total gastrectomy, which is bypassing the stomach itself. A vagotomy is an operation in which one or more branches of the vagus nerve are cut. It's to reduce the rate of gastric secretions or in the treatment of these peptic ulcers. You have to monitor vital signs. You have to monitor for pain. You have to introduce coughing and deep breathing. Keep IV fluids running. NG tube are you're to suction and not to touch the tube. You want to keep that in place. Vitamin B12 injections because the patient is lacking that intrinsic factor. And there's that Billroth 1 and Billroth 2, and you can see just where the locations of the surgical insertions are, and you can see what the duodenum is sewn up on one end of a patient, and the top half of the stomach is reconnected to the duodenum on the other one. So you can look at that for the particular procedure that is being done. Complications include hemorrhage, gastric distension, nutritional problems associated with it, stenatoria, which again is that a poor fat absorption in the stool, pyloric obstruction, and dumping syndrome, where all of a sudden you'll find the need to have a massive release of stools, and there's really no control over it. In assessing an ulcer, you have to get the patient to describe the pain. If there's any vomiting, and what kind? Is it projectile? Is there any blood? Is it coffee ground? A food intake over the past 72 hours, their lifestyles and habits, drinkers, smokers, vital signs, and do an abdominal assessment. Nursing diagnosis would include pain, anxiety, nutritional deficits potentially, hemorrhage, perforation. Outcome include pain relief, decreased anxiety, prevention, and education. Interventions include trying to relieve pain, trying to provide nutrition, appropriate nutrition and relaxation for stress, hemorrhage to replace fluids, vital signs, monitor H&H, monitor urine output, potentially install an NG tube and O2. Perforation will require surgery, education on diets, meds, avoiding certain meds and foods, evaluate for no pain, no anxiety, knowledge of diet and meds, and no complications. So you're looking at a picture of diverticula, which are small bulging pouches that can form from the lining of the digestive system. They are found most often in the lower part of the large intestine and usually like on the descending portion of the large intestine. They are common, especially after age 40, and they seldom cause problems. But if you look at them, they can collect debris. And collecting that debris, you can develop a sickness or a diverticulitis, where that becomes inflamed. That area becomes inflamed and infected, causing a lot of pain, requiring antibiotics. And a lot of times it can cause a perforation into the intestinal wall, and it can cause a fistula right with the bladder. And a lot of times you'll see stool emanating from the bladder, infection process big time, and it's usually requires antibiotics and sometimes a hospitalization. Diverticulitis can result from impactions or slow moving or sluggish stool, constipation, anything that's going on in the digestive tract, usually in the left lower quadrant. And you can get maroon or jelly-like stool if there's any bleeding. Diagnosis is with a colonoscopy, a barium enema. Please make sure you're monitoring the ESR or the SED rate, and you're looking at the white blood count. Treatment includes bed rest, diet, meds. Make sure that you're using stool softeners and IV antibiotics. Just another area of diverticuli in the intestinal tract. Nursing care includes, don't give morphine. It increases the intraluminal abdominal pressure in the colon. Surgery, if severe, sometimes you have to resect. And an anastomosis is where once they resect, they reconnect both ends of the intestinal tract. Temporary, sometimes they have to go to a colostomy. Complications can include perforation and peritonitis. If there's no surgery, you're drinking a whole bunch of fluid, you're maintaining a high fiber diet, low fat, no seeds, exercise regularly. When a person is not having or not experiencing any side effects or symptoms, they can go back to some degree of food that may have seeds in it. But while they're having those areas of inflammation, you want to avoid fiber and you want to avoid seeds. Nursing care, of course, assess for pain, bowel movement patterns, diets, and particularly habits. Fiber, abdominal assessments. Make sure you're monitoring for bloating and your vital signs. Is there any history of constipation? Is there any pain? Is there any bleeding? Please monitor for peritonitis. Outcomes, maintaining a normal elimination, pain-free, free of complications. Interventions is to assess the abdomen and bowel movements per shift. Fluid intake, at least 2 liters per day. High fiber diet when they're okay. Abdominal exercises, at least once a day. Bulk laxatives, avoid nuts, popcorn. Pain relief measures, again, avoid morphine. Monitor vital signs Q4 hours, and educate patient on diet. Irritable bowel is a true psychological downer, unfortunately, because there's no known prediction of what will happen to the bowel on any particular day. The cause is unknown. Symptoms could be gas, bloating, constipation, and diarrhea. Pain relieved with a bowel movement. Diagnosis is usually done with a sigmoidoscopy or lactose intolerance test. Abdominal pain can last for three days per month or in 3 months, and so that's how you would diagnose it, the amount of time you're in abdominal pain, with relief with a BM. And the change in stool frequencies and form. A lot of times the BMs are not controlled. It's all of a sudden a patient with irritable bowel just has to go and they have to get up and leave. Otherwise, they will have an accident. Treatment is to control stress, fiber, give meds, give Metamucil, watch for those anticholinergics, but one of those things, antispasmodics, especially during times of exacerbations, probanthine or bentyl, and antidepressants. Antidepressants can relieve the anxiety, sometimes reduce the amount of stomach irritants. And guys, study hard. This has been a really, really tough semester. You've all done a great job, and you've all done the best, and we've all done the best that we can do. So congratulations, and please stay healthy.